Um, my name is Simon Abi Aad. I'm a medical oncologist. I'm currently with Florida Cancer Specialists in Naples, Florida, and I will be making the transition back to the East Coast to join Florida Precision Oncology, which will be in Aventura and in Boca Raton. Today, I was asked to talk about something called molecular intelligence, mostly next-generation sequencing. It's a little bit of a dry subject, so I'll try to make it as, fun as possible. So my disclosures, I'm at the Caris Speaker Bureau, and this is where we started. When I was in med school, we used to get, and that was a long time ago, but when we were introduced to lung cancer, they told us that we had adenocarcinoma, large cell, small cell, and squamous cell carcinoma. And then as I started my residency and then my fellowship, things started to get more and more complicated. And then we started going into molecular subtypes. So then we came up with, we found the EGFR, I think it was back in 2005, and then we got a target for it. And then we found the ALK, and then we found ROS1, and then we found the RET, and then we found the HER2, and then we found the BRAF, and then we found the KRAS, and we're still going. There's the MET14. We're still going on with these things, and they changed the whole perspective of how we treat cancer, because now we test for this genomic profile, and based on it, I always like it when I tell a patient, we're not going to give you chemo, we're going to give you a pill. And they think, oh, they're going to treat my cancer with a pill, which is kind of true because we're going for a targeted therapy. What they don't think about is that this pill can have more side effects than chemo, but that's for another talk. But this is what we've been facing, and I'm going to bring this up because one of the challenges that I've had a stint with pharma a few years ago, and I was responsible for, one of the products I was responsible for was bevacizumab. And bevacizumab is an anti-VEGF drug. It works on a target. It has a target, but the idea is we have never, and we still don't have a way to test for VEGF. So even if the patient comes back, and I'm just going to give the example, VEGF positive, which isn't a thing, but anyway, and they tried to do trials of that sort, and they found out that it has no meaning. We cannot follow that target. So the response rates for bevacizumab have not been as great as you would think because we didn't really have a specific target. But then you look on other drugs, and let's just say a CD20 targeted therapy such as rituximab, and you see if a patient is CD20 positive, we have a very high likelihood that this patient is going to respond. If a patient is KRAS wild type, we know that they're going to respond to cetuximab, panitumumab, and other drugs. So the more we can narrow the target, the better our drugs are going to work. And these are not cheap drugs. These are extremely expensive drugs. So throwing a $10,000 drug a month on at a patient, not knowing if this patient is going to respond or not, is costing the community a lot of money and not really helping the patient. Precision. We talk about precision medicine. Everywhere you hear personalized care, precision medicine, all of that stuff, precision oncology. And we use that word, we overuse that word in oncology because we are the leaders in it. We are the people who have created this discipline of pharmacology and medicine, and we are still and we remain the leaders in that particular field. So, as you all, I heard there's a whole lot of nurse practitioners here, and I don't know if there's doctors, but what we have, whenever we talk about next generation sequencing, NGS, it has become standard practice. A patient comes in, we get a tissue biopsy, and then we send their tissue to a company to do next generation sequencing. There's several on the market. I'm going to name a few. It's a non-exhaustive list. There's Caris, there's Foundation One, there's Tempest, there's et cetera, et cetera. And they each have their own way of doing things. But what is the ideal next-generation sequencing that we are looking for our patients? And I'll explain how this importance comes into play. We can find a target through several ways, and these are all lab assays. And this is what I'm not going to get into because it's dry, it's annoying, and nobody cares except the people who do it. But anyway, the first thing we need to look at is sequence the DNA, sequence the genome, right? But then the genome has parts of it that are not really the main disease drivers. So we have the RNA, which is kind of a consequence of the genome. And then you have the resultant of the DNA to RNA to protein, which is the protein expression. So if we want to go back historically, we have done a good job testing for protein because we have immunohistochemistry, which is something that can be done at your local path lab. And they put a stain, they do something, they find out, oh, the patient has an expression of CD20. But then things got a little bit more complicated, and then we couldn't really use IHC for everything. So we started using sequencing and RNA sequencing, and we kind of perfected our technique. So how does next-generation sequencing work? We send the patient for a biopsy. We get the biopsy, whether bone marrow or tissue. We send a paper to the lab. We tell them we want next-generation sequencing, and this patient has lung cancer, for example. The lung cancer tissue is, they call the lab where the biopsy was done. They take it to their centralized lab. They use high-end techniques that I discussed to sequence all that they need to do. And then they analyze that information because you're going to get a lot of things. And unfortunately, what we know right now is the tip of the iceberg. So sometimes when I'm doing genetic counseling on a patient, and for example, in breast, and these patients don't come back as BRCA1 or BRCA2 or PALB2, or when they come in for unknown mutations, or the report would usually say no identifiable known mutations. And what I tell the patient, and that's a patient that had like 2 breast cancer and her whole family had breast cancer. And what I tell this patient is that I know you're getting something that says no and that everything's fine, but we don't know everything. And there's things that we still don't know. And if you look at those reports and details, you see a mutation of unknown significance. So it's a lot more, we still don't know much. So, but anyway, what these labs do, and I think it's a great thing, and all of them do it, they analyze the data that they have, they compare, they look at studies, and then they come back to you and they say, you know what, we found these things, we think these are alterations or mutations or targets that you can use, whether in the sense of a clinical trial or even that you have a drug on the market that you can use for it. So the NCCN, for them to accept a next-generation sequencing and to recommend it, they have put in a lot of criteria, and it all comes down to the same thing. You got to go from DNA to protein. So you have the IHC, you have the RNA sequencing, you have the DNA sequencing, and there's the other stuff that are a little bit too complicated and not really used in the clinical world. They're used in the research world. But as you can see, from RNA sequencing alone, we can find targets for, and that's a non-exhaustive list for targeted therapies. And then in IHC alone, you can, and this is also non-exhaustive, you can find out if the patient has PD-L1 positive and whether this patient will respond to immunotherapy or not. And then you have the DNA sequencing, which is going to show you EGFR, ALK, RAS, and all the other stuff. This is an example, and I'm sorry, I don't know if it's very visible, but this is an example of a next generation sequence and sequencing company and what they do for different types of cancers. So for example, let's take breast cancer. The IHC will give you androgen receptors, hormone receptors, HER2, MMR, PD-L1, and other stuff. But then they kind of double down on that with, they look for mutations, they look for MSI, which I will discuss later, tumor burden, fusion analysis, and deleterious mutations. So that's just an example of the genes that are tested. You have all these genes. You have 592 genes. And then for the RNA, and there's different techniques. There's hotspot and there's whole transcriptome. But the hotspot doesn't cover intronic, okay. It doesn't cover areas where the RNA is not expressed. It's a little bit of a different technique, but basically the whole transcriptome sequences all of the RNA that you have. So the RNA cannot hide when you have fusions or other variations. So I'm going to start with immune checkpoint inhibitors, and I'm going to talk about what the progress that we have made with these drugs, and some of them are getting approvals based on things that are different than PD-L1. And as we have practiced more, we have realized that PD-L1 doesn't really change the course of things. And there's several things that come into play. You have the microsatellite instability, you have the tumor burden, tumor mutational burden, and you have the PD-L1. And initially, when we first discovered immunotherapy, we thought that PD-L1 was the all-be-all. And actually, the drugs, if you look at their clinical trials, they were made in a way where if a patient is PD-L1 negative, they would not be part of the trial. And then all of a sudden, we realized that no, as a matter of fact, you can include these patients in your trials, and they actually still benefit. So tumor mutational burden. It's, I'll just give the example of head and neck cancer. You have or lung cancer. You have a patient that has smoked their entire life. We all know that cigarettes are mutagenic or whatever. I'm sorry, I have a little bit of an accent if you didn't pick up on that. These patients, they have been causing insult and injury to their DNA all their lifetime. So they have a lot of mutations that the DNA eventually cannot fix. And they develop something called a mutational burden. And then one day, this lung cell or this head and neck cell is going to say, you know what, I'm done. I'm going to go crazy and I'm going to become a cancer. So, so this is how it is. And then these patients have usually, lung cancer patients and head and neck patients who have been smoking their entire lives, have a high tumor mutational burden. What does that mean, though? It means that cancer has very abnormalities. So when the immune system is policing our body, looking for what's normal and what's abnormal, it's kind of like a freak walking around, and the immune system is going to pick up on it, especially if you help it out with a little bit of immune therapy that will uncover these weird cells. And MSI is not something that you kind of sign up for. It's something that you are, I would say, born with. And it's the DNA repairing itself. And the DNA has something called a mismatch repair system, which is fascinating how nature works. The DNA polices itself when it's replicating. And when it picks up that there's something that doesn't make sense, it does something which is called a repair. It repairs it. And if it cannot repair itself, it actually kills that cell which is trying to replicate. unfortunately, in a subset of people, we have that instability. So the body kind of doesn't do the best job at picking up at those mismatches, and over the course of years, you have more and more abnormal cells which develop into cancer. But they're also unique, and the immune system can uncover them. And this is why immune therapy works in this particular type of patient. PD-L1, the way I tell my patients what it is, because people ask, how does immunotherapy work? And I try to simplify things as much as I can, and this is what I came up with. I came up with that the immune system is kind of like a police. It's walking around, and it's asking for IDs. And every one of us needs to show them our ID. Cancer carries a fake ID. But then the police does not really have, the thing they use at the club. So it just falls for it, right? And it always happens to me. I go there and they don't believe they think I'm younger than 21, and I'm like, no, I'm not. But anyway, but what immunotherapy does, if you want to simplify it, is that it gives the immune system that power to identify a fake ID. And when it identifies the fake ID, it will do its job and take this cancer away. So, just to show you how much of a difference these three things do. You have a lung cancer patient. If he has a little bit of an expression of PD-L1, that's the example of PD-L1, and you give this patient pembrolizumab, which is an immune therapy, you're going to see that they're not going to get that great of a benefit. Their median isn't that fascinating. If you have a patient with more than 50% of its cells expressing PD-L1, all of a sudden our overall survival is superior to chemotherapy. So if you have a patient who has more than 50% PD-L1 positive cells and you give them an immune therapy, chances are they're going to do much better than with chemotherapy, in addition to much less side effects. So, and this was a presentation at ASCO this past year where they discussed that, and it was a plenary session. So that's a big achievement in treating cancer for us. And mind you, these patients respond for a very long time. So you are getting like triple the overall survival in patients who respond. Now, colorectal cancer. Colorectal cancer, PD-L1 doesn't really do much. The main difference has always been MSI, and which is microsatellite instability, the ability of the body to correct itself. For the longest, when we used to give chemotherapy, we always had this struggle where we knew about MSI years ago. And when we always had this, there's a small early stage subgroup of patients who have MSI. These patients don't do well with chemotherapy. They don't do well with chemotherapy for various reasons. One of it is that the normal tissue cannot correct itself after it's hit with chemotherapy. So basically, you cannot correct the damage, and you're kind of almost doing more damage by giving these patients chemotherapy. And then you have, so there's a subgroup of patients who had MSI with early stage colon cancer that we would not recommend adjuvant therapy to these patients. We would say, we don't think it's going to do you good. As a matter of fact, it will do you harm. Until we got immunotherapy involved. And now our patients who have colon cancer have this wonderful new advancement where instead of a patient having a stage 4 colon cancer, and look how quickly their progression happens. In 3 months, even less if you take the median. Now with patients who are MSI and you give them pembrolizumab, which is also an immune therapy, we have changed the whole paradigm of colon cancer. And then the tumor mutational burden. Bladder cancer is one of those cancers that, again, is induced by smoking or by other chemicals. And so they have a lot of mutations in that cancer. And you can see that atezolizumab, which is another immune therapy, also has changed the paradigm in treating these patients. So, I think I talked about this quite a lot, right? But anyway, to test for tumor mutational burden, this is what's happening. We don't have a standard yet. So every company claims that they test for it, and every company gives you a report that says high, low, medium. But every company's high, low, medium is different. And we don't have a standard yet. There's not a single test that says, oh, these guys are right or these guys are not right. So what's happening with that is that there was an immune therapy combination that was going to be approved based on tumor mutational burden. And the FDA approval was imminent, and then that company had to retract its FDA application because of the fact that they couldn't really tell them what is a high tumor mutational burden. Microsatellite instability. This slide tells you how historically we used to test for it. So what we used to do, we used to use PCR, which would miss a little bit of the MSI patients. Now with next generation sequencing, there is no way we can miss it. Look at the data. You have, if you take PCR versus next generation sequencing, you can see that we have increased the sensitivity to 100% and the specificity to 99.9%. PDL1, this is kind of talking shop, but there's 5 FDA, I don't know if it's the FDA, I don't know. Yeah, 3 FDA-approved diagnostic assays for PDL1 and for 5 different disease types. And you have to use the correct assay for the correct patient. For example, and that's something that also some companies are capitalizing on. For example, for atezolizumab, which is an immune therapy drug that was approved in combination with NAB paclitaxel, it's not approved yet, but the data is out and it will be. In triple-negative breast cancer, an area of unmet need, we have not had any progress in that particular disease area, and immunotherapy trials have failed us countless of times in triple-negative breast cancer. And then finally, we had this, this beacon of hope where atezolizumab was found to be effective in a particular subgroup of triple-negative patients who have a PD-L1 positive expression. But the study was made with the SP142 Ventana, and that is the only assay that would allow you to get atezolizumab in these patients. So if I go to an insurance company or a payer and I tell them I did the DACO assay on a breast cancer patient, they tell me we're not going to give you atezolizumab because the FDA approval is going to come out by SP142 Ventana. Now, I'm going to touch up on the NTRK fusion. That was the first, and that is the first FDA-approved drug that is agnostic. So this drug has no place in America. No. But it's an agnostic drug, and what that means is that the study was not made to target a specific type of cancer. It was only based on patients who had an NTRK or NTRK gene fusion, which was, I would say, a very smart way to do things, but also a very risky way of doing things, because we know for a fact that there's mutations in, for example, a HER2 positive lung cancer patient, the early data did not show a benefit of trastuzumab in those patients. So we don't use trastuzumab in lung cancer patients except in very particular clinical trial, hyper-specialized circumstances. So this drug that came out, larotrectinib, took all incomers with NTRK mutation, and we tested the drug on them, and the efficacy was regardless of tumor type. And as a matter of fact, what's really amazing about this drug, because our pediatric population gets the drugs really late because we're afraid to test things on children, but why not? By not testing them on children, we're denying them hope. So they took pediatric and adult cancer patients, and they just gave it to everybody. And it works. Unfortunately, it only works in less than 1% of our patients. So it's not like everyone will get an NTRK mutation. So NTRK is a hot topic with all NGS providers. And the reason is they all have different claims. Some of them, first of all, when it first came out, there's NTRK 1, 2, and 3. And when it first came out, everyone said, oh, we test for it already. And then once you start looking at the intricacies of the test, they test for NTRK 1 or NTRK 1 and 2, and they miss one of them. And some of them even miss the resistant mutations, which are essential for you to get the drug, because if you have a resistant mutation to that particular drug, you can't use the drug. So some companies didn't even test for those. So it made it a little harder. I mean, we already have less than 1% of these patients getting the drug, and now we're kind of narrowed down a little more because we're missing a good bunch of these patients. So the best way to do it is with full transcriptome sequencing, because that way you will cover all the mutations, all the resistant mutations, and when the mutation tries to hide in a particular type of fusion, you will catch it. Now, I'm going to tell you a story of one patient who I've seen. He's a 54-year-old man who smoked his entire life and then went to a very highly well-renowned cancer center. And the patient was started immediately on chemoimmunotherapy without NGS testing, because he was told it's squamous cell carcinoma, and we don't test squamous cell carcinoma for mutations. He failed, he blew through his first line, and then they started putting him, as we all know, on clinical trials. Failed one, failed the other, and then they told him, go to hospice. So he came to see me in my small clinic for a second opinion, but what do I know? So I sent a next generation sequencing on his initial tumor, and it came back with an exon 14 mutation and a BRCA1 mutation, and he was negative for PD-L1. So this patient, and this is going to show up as my presentation goes further, if you have a targetable mutation, immunotherapy works very badly. So this patient did not do well with any of the chemoimmunotherapy things that they gave him, because he had an actionable mutation which is treated with crizotinib. So I gave him crizotinib. He had a great response on it for 7 months. And then after that, I made my way to get him olaparib, which targets BRCA1, even though it is not approved, but this is a CME talk. And he had stable disease for another 5 months. And he eventually passed away, but I don't know what would have happened if we started this in reverse. So if he had received the targeted therapy initially, maybe he would have lived longer. And what I want you all to think about is that next generation sequencing should and is the standard of care in 2019. Whoever the doctor is, if you're working under the supervision of a physician, whoever it is, if he tells you no need to do it because blah, 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 just ignore it. Okay? Smile and wave and go fill out the form. And so I send next generation sequencing on all my patients. So we've made strides. We went from IHC to we're sequencing the whole DNA and RNA genome. We still don't know a lot. Those 592 genes that I spoke about are nothing compared to what still remains in hiding. But slowly but surely, at least now we can see them. Before that, we couldn't see them. Now we're seeing them, and there's people in the background analyzing what these things that are showing up mean. We have perfected the techniques, and we're still perfecting them. Now we have more accurate results, which are helping us have more, we can zoom in more on our targets, and we can follow them with therapy. And basket trials, I believe, are going to become the standard of clinical trials in the future. And what is basket trials? Basket trials is that they take, like the NTRK drug, they take patients with a certain mutation and they go after it. And there's actually a huge clinical trial happening by the NIH, and it's called the MATCH trial. And what the MATCH trial is, it's also an agnostic trial. And what they take the mutation and they treat it with a target. And they want to see if we can change how we see cancer. So instead of me presenting the case with invasive ductal carcinoma of the breast, it will become adenocarcinoma with mutation X and Y and Z. And I treated it with this target instead of treating it as a breast cancer. So this might change how we talk about cancer, how we treat cancer, and then I have to go through fellowship again. So I'm going to speak about comprehensive liquid biopsy, which I also find to be amazing. Here's what I face in clinic every day. I send a patient. I had this breast cancer patient who came up to me, and I did a biopsy, and she had triple negative breast cancer, even though it's a relapse of a hormone positive breast cancer she had a few years ago. It's not unheard of, it happens. But then I wanted to get more information. Like I said, I send it on all my patients. I wanted to send next generation sequencing to find out what's going on with this patient. My biopsy for her relapse was from a lymph node. So I sent it to the lab, and the lab came back to me and told me, not enough tissue. So at this point, I'm stuck. Do I send this lady for another biopsy? We all work with cancer patients, and it's just, you need to barely touch them because they're already so fragile when it comes to their state of mind and whatever. And then when you tell them, oh, you know what, that biopsy, I need another biopsy, it's going to create even more psychological distress on them. And I try to avoid those things. And I'll go back to what we do for these patients. But what happened here is that this study found out that out of 5,688 advanced non-small cell lung cancer patients, less than 50% were treated for their ALK and EGFR mutations, which is ridiculous, right? And why? And I'll tell you why. I get a patient, he has pleural effusion, he's dyspneic, he has 10 things going on, and I need to send NGS on him. NGS turnaround time, I would say, is about 10 days. 10 days, I need to, in medical terms, dry him out from his pleural effusion. So what I end up doing is starting chemo. When I start him on a non-targeted treatment, chemoimmunotherapy, my goal is to relieve his symptoms acutely, and I cannot wait 10 days. And in 10 days, they might come back not enough tissue, right? So I start him on like kind of an empiric treatment, but what I'm missing in this patient is that this patient might have a mutation, just like our previous patient, and then he's not going to respond, and then I'm going to play catch up with his disease, and then he's going to I'm going to eventually lose him. So these are the limitations of next generation sequencing tissue samples. This is an example of a lady who is 64. She came in for a stroke, was found to have a lung mass. They did an EBUS. They found a lung carcinoma. Just to let you know, EBUS is not the greatest thing to get tissue biopsy. Usually they end up getting an FNA or whatever just to let me know, oh, that's cancer. So there wasn't enough tissue to do genomic testing on this patient. And she was treated with conventional therapy, and then she started progressing, and then what do we do? So this is where liquid biopsy comes into play, and that's a blessing, right? You send the patient, they're in your lab, they're in your office, and then they draw blood on them, they send them, and this patient, for example, after 7 days turnaround time, came back with an EGFR L858R, which was at the time responsive to erlotinib. It is still, which is a targeted therapy, and this patient had a good year of life, which we couldn't have offered her had we not done this. So, treatment delays, because you're going to wait 10 days, and then they're going to send you a fax, or they may not, and then you have to call them, where's the tissue? Oh, we're still processing it. This could take up to 3 weeks, and I've had sometimes patients who ended up waiting 3 weeks to get their tissue, or something as simple as that. We've been calling the pathology lab for the past week, and the secretary is not answering, or she's we always have a finite resource with tissue, and we're doing so much testing on tissue that we're exhausting it time and again. We have the patient burden. If I'm going for a lung biopsies have complications. Pneumothorax, hemothorax, burst of bleb, I don't know. So it's easier to get a blood draw than to get a biopsy. And then, like I said, the practice burden, because the pathologist needs to be aware to, And this is another study, and it showed that we don't catch a lot of these patients. And only 8 patients were tested for all 7 recommended alterations. And the reason why is the pathologist looking at the tissue in front of them have to prioritize what they want to test on. So only 8% of patients get the full panel. Because of that, and I talked about this, look at the difference in response. From 60 to 70%, we're dropping to 14%, 4%, 13%, 7% response rates, whereas we could have these patients respond more than 70% of the time. So while we're waiting for this tissue, do we start chemoimmuno? Do we start targeted therapy? What do we do? And like I said, it's a simple blood draw, and what it does, it capitalizes on circulating tumor DNA. There's two ways of doing this. You catch actual tumor cells in the bloodstream, or you just catch the DNA that they're shedding. DNA is that the tumor sheds. It sheds it when it goes through apoptosis, necrosis, duplication, whatever it is, it's shedding DNA into the bloodstream, and we can catch it now. So that's when I first was introduced to liquid biopsies, I thought it was mind-blowing, and I started sending it on everyone. And then my program director was like, that's not how we do it. So I was like, no, breast cancer, you don't need a biopsy. I'll just send a liquid biopsy. So these are all, technicalities, but what I would say is that different labs use different techniques, and some labs catch cellular cells, and some labs catch circulating tumor. This is a list of an example of a liquid biopsy assay, and that particular assay is in guidelines. It's approved by Medicare, Medicaid, so it is, I would say, let's just say I personally don't know of another one, just because it is FDA and NCCN endorsed and all of that stuff. And look at the mutations they cover. They cover all of these things, which is fantastic. You're getting ALK, BRAF, EGFR. All the targetable mutations are covered by a single blood draw. Now, again, we know that tissue fails a lot of times because of limited resources and all of that. So what do? Do we accept it as and no, we don't. We go through liquid biopsies. And when do we add liquid biopsies to our workup? First of all, are liquid biopsies as accurate as tissue biopsies, next generation sequencing? And this was 6,948 patients. And they, take my word for it, they took them and they compared tissue to liquid. And they found out that you have a concordance of 98 to 100%. And this is what we found. This was very interesting. We found out that cell-free DNA, which is the liquid biopsy, versus tissue biopsy. And this is what they found. And they kind of did it in reverse. They took liquid biopsies first, and then they biopsied the tissue. And then they took tissue first, and then they did the blood draw. And they compared the results separately to see which one is better. And what they found out is that they're both just as good when it comes to specificity and diagnostic accuracy. But what they realized is that tissue has a sensitivity of 80%. Liquid biopsy has a sensitivity of 80 to 85%. So this one is missing 20%, and this one is missing 20%. And that was a concern, and this is what we came up with. They came back and they looked at the data. Are they missing the same thing? And thankfully, the answer was no. One catches one thing, the other one misses. So the 20% in the tissue area is not the